Good morning. My name is Kevin Choo. I'm a joint replacement surgeon at ONS, and this morning I'll be talking about a specific form of a partial joint replacement or a unicompartmental knee arthroplasty called Patellofemoral Arthroplasty or PFA. And I want to thank the ONS Foundation for the chance to discuss and thank our listeners for tuning in. So for our agenda this morning, we'll have a brief case presentation. We'll talk about the background and history of patellofemoral arthroplasty, or PFA. We'll discuss the appropriate indications for surgery, outcomes from this procedure. We'll also discuss comparative studies between PFA and total knee arthroplasty, or TKA. And as well, we'll conclude after the end of the discussion there. So for our case today, we have a 60-year-old patient who presents with left knee pain. Duration greater than 6 months, severe pain with activities. The location of the pain is localized to the anterior aspect of the knee. And in regards to the pain pattern, the patient presented with pain with ascending and descending stairs, as well as prolonged sitting. The patient attempted conservative treatment, which was appropriate, including NSAIDs or anti-inflammatory medications, steroid injection, and physical therapy. And despite this, had a fairly reduced or limited quality of life. So these are x-rays for our patient, and to orient you to the screen, these are both anterior to posterior, or AP or PA x-rays, and so they show us the joint between the tibia and the femur, so that's the tibiofemoral joint, as you'll see. And what we look at is, relatively speaking, the space between those two bones. So as you can see on the image to the left and to the right, on both of these views, there's still good empty space in between the tibia and femur. That space isn't empty, that's filled with normal, healthy cartilage. So looking at this x-ray, we would say that there does not appear to be significant arthritis, joint space narrowing in that compartment. When we consider the tibiofemoral joint space, we actually think of two smaller joints within it. And these would be the medial compartment, which is the first compartment of the knee, and then the lateral compartment, which is the second compartment. And as you can see in both the medial and lateral compartment on those x-rays, they appear to be quite normal, with normal-looking joint space. And that brings us to the last compartment of the knee, which is the patellofemoral joint, which is really the focus of our discussion today. We have the lateral x-ray to the left, and then the patellofemoral view to the right. And as you can see from both of these views, it's a little bit of a different story, as opposed to the previous x-rays where there was maintained joint or empty space, which indicated presence of normal cartilage. As you can see from these x-rays, in particular, the x-ray to the right, the joint between the patella, which I'll point here, and then the femur here, is significantly diminished. And in fact, in this portion of the patellofemoral joint, there's actually no more remaining healthy cartilage. And so we would describe this as being severe osteoarthritis of the patellofemoral joint, which is the third compartment of the knee. So what are the options? Now, generally speaking, we talk about the appropriate treatment for osteoarthritis, severe arthritis of the knee. And if you look at the illustrative example to the left of the slide here, you can see what it looks like in a normal, healthy knee, normal white cartilage, and then the tan is the bone. And then in an arthritic knee, you'll have several important changes, including cartilage loss, joint space narrowing, and bone spurs. To the right slide here, you'll see an actual clinical picture of above normal arthritis in an articular joint, smooth, lubricated joint, and then below an image of an osteoarthritic joint. As you can see, it's inflamed, the contour isn't smooth anymore, and that can be quite painful. Now, regardless of the severity of the arthritis, we generally endorse a conservative approach initially. This can involve things such as medications, physical therapy, wellness and weight loss, injections, which can include steroid or viscosupplementation injections, which are sometimes known as gel injections. And for many patients, that can be quite effective. However, for patients who do not have a substantial or significant relief with non-operative treatment, we then have to discuss operative management. And for the management of severe osteoarthritis of the knee, there are really two good approaches to this, and these would include unicompartmental knee arthroplasty, or UKA, also sometimes known as a partial joint replacement, and total knee arthroplasty, which is what we conventionally refer to as a total knee or a joint replacement of the knee. Now, for the history of patellofemoral arthroplasty, or PFA, again, it's important to note that PFA is really just a specific type of a UKA, or a unique compartmental knee arthroplasty. Remember, before I mentioned the three compartments of the knee include the two joints within the tibia and femur, medial and lateral, and also the patellofemoral joint. The origin of partial joints really began in the 1950s, and these were thought to be a more conservative approach to total knee arthroplasty. But these were not very successful procedures early on, and they were plagued by a relatively high risk of revision surgeries, which meant a conversion to total knee replacements. And these were probably related to a few things, including implant-related factors for the design and geometry of these implants, surgeon factors for the technique, as well as patient selection. When we consider the earlier evolution of these implants, or the first generation of patellofemoral arthroplasty, these were characterized by what we call now an inlay design. Now, what this meant is that surgeons during the procedure would be able to resurface the cartilage, but weren't able to underlie any of the underlying subchondral bone. And so positioning of the implants depended entirely based on the patient's normal anatomy. And as you can imagine, patients who are predisposed to having severe osteoarthritis of the patellofemoral joint, that anatomy can be sometimes suboptimal in regards to the positioning of the implant. And so these surgeries were associated with a relatively high rate of malpositioning and subsequently early failure. The current or contemporary implants we call second-generation implants, and these are characterized by an onlay design. Now that means that surgeons do not have to rely on native anatomy, and it allows the surgeon to determine the appropriate positioning and in particular the rotation of the component. And these have been associated with significantly better survival and longevity and improved clinical outcomes compared to the previous generations. Now, for indications of patellofemoral arthroplasty, we often talk about the appropriate patient selection, and I really think that for this specific procedure, this is very, very important. The ideal candidate for a patellofemoral arthroplasty should really have isolated patellofemoral joint arthritis. Again, you should see joint space narrowing only in those two views I mentioned before, the lateral view and the patellofemoral joint view, relatively spared joint between the tibia and the femur. These patients should have non-inflammatory arthritis, so these patients should not have arthritis such as rheumatoid arthritis or psoriatic arthritis, which typically involve the global joint. And also patients who are affected by post-traumatic arthritis and arthritis secondary to trochlear dysplasia tend to do quite well with this procedure. For the clinical presentation in the office, patients should be expected to have primarily anterior or retropatellar knee pain. And in fact, in the office, I'll have patients attempt to localize their pain with one finger. And we really hope that these patients have pain that really seems to localize to the PFJ rather than to the tibiofemoral joint. In addition, activities that load the patellofemoral joint should be more painful. So pain should be worse with activities such as ascending and descending stairs, as well as pain with prolonged sitting. Relatively speaking, they should have less pain with activities that load the tibiofemoral joint, which would include things such as prolonged standing and walking. Now, that's not necessarily a hard and fast rule, and most patients have some combination of pain between those different types of activities, but ideally you have a patient who majority of their pain is from activities that load the PFJ. Not to belabor this too much, but this is a table just describing some of the small retrospective studies describing the outcomes of PFA. And for our interested viewers who want to go back and look at the slide or pause here, you can take a closer look at the specific numbers. But the overall point here is that PFA procedures are quite successful overall with a low complication rate. Now, when we consider the use of PFA versus total knee arthroplasty for patellofemoral arthritis, there's a few benefits of PFA, including reduced morbidity. These patients can often have surgery on an outpatient basis. They usually have less pain compared to a total knee arthroplasty, faster recovery. They usually have improved kinematics as you spare the majority of the remainder joint, obviously, including the cruciate ligaments. And these patients tend to have better functional outcomes. And as you can see from the x-rays to the right of the screen, you can see really how much they look different in terms of a PFA to the left and a total knee arthroplasty to the right. And if these look a little bit similar to you, they should, because if you look at this circular portion of the PFA, all this is really doing is recreating this anterior part of the total knee arthroplasty. But as you can see, you're not resurfacing or replacing the remainder of the joint. So relatively speaking, it's a less invasive procedure in regards to the amount of bone and cartilage removed. Here again, you can see some clinical pictures of what a PFA looks like to the left, and then a total knee arthroplasty to the right. In regards to studies that look at PFA versus total knee replacement, again, you have to look at overall the differences between any partial joint replacement procedure, or UKA, versus a total knee. And what the studies show, generally speaking, is that UKA procedures, or partial joint surgeries, have a relatively shorter lifespan compared to total knee arthroplasty. And this is corroborated by all the large joint registry data studies, as well as recent meta-analyses. And I'll just focus on those numbers here. I think these are good numbers to remember if you're considering the surgery or if you're talking with a patient who is considering this, which is that partial joint replacements, at the bottom here, again, unicompartmental knee arthroplasties, or UKA, overall do quite well. 86% survivalship at 15 years and 70% at 25 years. So it's not a bad longevity, but when you compare it directly to total knee arthroplasty, there's no doubt that total knee arthroplasties tend to last longer, 96% survivorship at 15 years and greater than 82% at 25 years. So it is something that's important to consider. When you directly compare PFA versus total knee arthroplasty for isolated patellofemoral arthritis, there are very few prospective comparative studies. This is one meta-analysis that looked at 28 retrospective studies, and they found overall that there was a higher complication rate in the PFA group when compared to total knee arthroplasty overall. However, when you considered only the newer implants, which were the second generation implants which I mentioned before, there really was no difference. So I think what this paper showed was that overall, with the use of a newer implant, the complication rate between PFA and total knee arthroplasty are relatively similar. To my knowledge, this is the only randomized controlled trial comparing PFA versus total knee arthroplasty. And this was actually an interesting study, again, a randomized controlled trial. Amazingly, the patients themselves were actually blinded for the first year postoperatively, so they actually weren't aware which procedure they had been given during the time of surgery. And here they found overall PFA was generally superior to total knee arthroplasty. Patients had improved clinical outcomes at 2 years postoperatively, and they had better patient-reported outcomes and improved knee range of motion in the PFA group compared to total knee. Notably, the study was not adequately powered to compare the risk of revision. So I think between these two studies, I think the overall conclusion is that PFA versus total knee arthroplasty is likely a better implant and better surgery in regards to function, kinematics, range of motion, and pain, but likely not a superior surgery or implant in regards to longevity or risk of revision surgery. So for this patient, 60-year-old man with isolated patellofemoral joint arthritis. In addition, he had a pain pattern in physical exam which was consistent with isolated PFJ, or patellofemoral joint arthritis, and was so appropriate candidate for PFA. And I think importantly at the bottom you can see informed consent. So for all the reasons that we discussed earlier, for patients and surgeons who are considering these procedures, it's important to understand fully the risks and benefits before undertaking this procedure. And these are the postoperative plain films. Again, this is our anterior-posterior AP X-ray on the left, showing the anterior aspect of the patellofemoral joint here. The lateral view in the middle of the screen, showing the articulation between the PFJ, the metal flange anterior to the femur here, and then the back side here is a plastic button behind the patella. And again, on the right, our patellofemoral view shows the patella evenly distributed and centered over the anterior flange of that PFJ. So in conclusion, again, patellofemoral arthroplasty, or PFA, is a specific type of unicompartmental knee arthroplasty, or UKA. It can be a very good option in patients with isolated arthritis to the patellofemoral joint, but again, patient selection is very important for this. Informed consent is also very important. So here we have to weigh the risk for possible repeat surgeries in the future against the potential for faster recovery and improved function compared to total knee arthroplasty. And then last, we know overall that the burden of revision knee surgeries are increasing, and so when we consider overall, in a public health standpoint, consideration of a partial joint versus a total knee, it is also helpful to consider the risk for revision surgeries and what this costs on the individual perspective as well as to the healthcare system. Thank you.